You've probably heard of stacking treatments in skincare. I mean, it's kind of everywhere right now.
Oh, yeah, definitely.
Like a little vitamin C serum here, maybe a fractional laser there, layering on some peptides before bed. If you look at the current aesthetic landscape, we are just fully immersed in this era of maximum optimization.
Right. Everybody wants to do everything all at once.
Exactly. You stack therapies because you want to get the absolute best result in the shortest amount of time. But what happens when you take that exact same philosophy and you apply it to an intense heat-based laser and then combine it with an injected gel filler?
Oh, man.
And not just anywhere, but right in one of the most sensitive, densely innervated areas of the human body.
Yeah, I mean, it is basically the ultimate collision of cosmetic ambition and basic physics. And the results, well, when you actually look at what happens under the skin, they are structurally disastrous.
Which is exactly what we're unpacking in today's deep dive. We are looking at a really highly specific question. Can fractional CO2 laser therapy be safely performed over an area that has previously been augmented with a hyaluronic acid G-shot?
Right, and it's a fantastic question.
Yeah, and to figure out if this kind of stacking is a brilliant biohack or just a complete physical disaster, we're pulling from a pretty deep stack of clinical dermatological studies, technical specifications on 10,600 nanometer CO2 lasers, and some really fascinating histopathological data on cross-linked hyaluronic acid fillers.
Because the answer really involves looking closely at the physics of light, how heat behaves, and, the incredibly complex anatomy of the anterior vaginal wall.
Right.
Because to really understand why these two specific treatments fail to interact safely, you have to understand what each one is fundamentally trying to achieve in that exact same physical space.
Okay, so before we start firing hypothetical lasers into the tissue, we probably need to understand the environment we're working in, right? The G-shot itself.
Yeah, let's start there.
Because we hear a lot about it in pop culture, but scientifically speaking, this area of anatomy is still the subject of massive debate.
It really is. So the Grafenberg spot, which is what you probably know as the G-spot, was first formally described by a German gynecologist named Ernst Grafenberg back in 1950.
Okay.
And he noted this highly sensitive area on the anterior or front wall of the vagina that seemed to swell during stimulation. But for decades since then, researchers have been arguing over what that tissue actually is.
Because it's not just like a single standalone button waiting to be pressed, right? The sources point out that anatomists often can't even agree on a distinct structure when they do physical dissections.
Exactly. The prevailing scientific consensus in a lot of these clinical studies actually leans away from the idea of a completely unique, separate organ.
Oh, really?
Yeah. Instead, researchers propose that what a person is actually experiencing when that area is stimulated is the internal portion of the clitoris.
Well, that makes sense. Specifically, the clitoral crua, which are sort of like the internal roots or legs of the clitoris that wrap around the vaginal wall. And that's combined with the urethral sponge, which is this cushion of tissue surrounding the urethra.
So it's much more of a complex convergence zone of different sensitive tissues pushing against that front wall.
Right.
But wait, if scientists are still actively debating whether the G-spot even exists as its own distinct anatomical structure, isn't injecting it with a filler just kind of an anatomical placebo? Like you're just putting volume into a random wall of tissue and just hoping for a result?
It's easy to assume that. But if you look at the nerve density in that specific region, the sensitivity is absolutely real, regardless of how we classify it in a medical textbook.
Okay, fair enough.
The anterior vaginal wall in that specific zone is just densely packed with nerve endings. So the G-shot is a non-surgical outpatient procedure that's designed to physically exploit that nerve density.
Right, and they do that using filler. Exactly. A clinician takes a cross-linked hyaluronic acid dermal filler, and this is the exact same material used to plump lips or cheeks, like Juvederm or Restylane, and they inject it directly under the mucosa into that highly sensitive zone.
The goal being to physically push that tissue out, right? To increase the projection and the physical volume of that zone, expanding it to about the size of a quarter, like a 5p coin.
Yeah, because by adding that structural volume directly underneath the mucosa, you are physically pushing those sensitive structures forward so they protrude into the vaginal lumen.
Right, altering the topography.
Exactly. It physically alters the topography of the space, making that dense network of nerves much, much easier to stimulate through friction.
It's essentially like pitching a tent from the inside out so you can find it easier in the dark.
That is a perfect way to put it, yeah.
You're creating a physical mound that wasn't there before?
Yeah.
But what really stood out to me in the data is the specific type of hyaluronic acid they use.
Right, the cross-linking.
Yeah, it's not a liquid, it's quote-unquote cross-linked. Can you break down why that chemical distinction is so crucial here?
Definitely. So, natural hyaluronic acid, which is the kind your body produces every day, is a liquid,
Okay.
and it turns over very quickly. Your body basically breaks it down in a matter of hours or days.
Fast turnover, right.
Right. So if a doctor injected natural liquid HA into that area, it would absorb into the surrounding tissue almost instantly, and you just lose all that volume you just paid for,
Oh, wow. Instantly.
pretty much. So to make a dermal filler that can actually hold its shape and project that tissue forward for months at a time, scientists have to chemically alter it.
By cross-linking it?
Exactly. They use this process called cross-linking, which physically binds the long chains of hyaluronic acid molecules together, creating this three-dimensional lattice.
So they turn a fast-absorbing liquid into a highly durable, viscous gel. It basically becomes a structured implant.
A structured temporary implant, yeah.
Yeah.
Because of those cross-linked bonds, the body's natural enzymes take a much longer time to break it down.
How long are we talking?
The physical projection of a G-shot usually lasts anywhere from 3 to 5 months.
Okay, that's decent.
Yeah. And as for the safety profile, it's generally considered low risk when it's performed by an expert. You might see some temporary tenderness or maybe mild swelling.
Though I did see the clinical data note some rare but severe complications.
Yes, absolutely.
Like if the injection depth is wrong or if the volume is too high, that firm gel can press against the urethra and cause urinary retention. Or, in extremely rare cases, it can actually lead to fistula formation.
Right, it's a medical procedure. There are always risks.
But generally, the patient is left with a targeted pocket of firm water-binding gel sitting right under the surface of the tissue.
Which brings us to the core of the problem we're discussing today.
Right.
You have this patient who is specifically paid to have this structural volume added. And then perhaps a few weeks or a few months later, they decide they want to address the overall health, tightness, or elasticity of the vaginal tissue itself.
Right, because if the G-shot is all about physically adding volume to one very specific spot, it begs the question, why would that same person then introduce an intense heat-based laser into that exact same space? What is the laser trying to fix that the filler doesn't?
Because the laser is treating the tissue quality itself, not just adding volume.
Okay.
We are talking specifically about the 10,600 nanometer wavelength fractional CO2 laser. In aesthetic medicine and urogynecology, this technology is primarily used to treat tissue atrophy, laxity, and a very common condition called genitourinary syndrome of menopause, or GSM.
Let's actually pause on GSM for a second because the physiological changes there are really the main driver for why someone seeks out this laser treatment in the first place. Right?
Exactly. When estrogen levels drop, and this could be due to menopause,
Yeah.
certain medications, or even postpartum changes, the mucosal lining of the vaginal wall thins out significantly.
It just degrades.
Right. It loses its elasticity, blood flow decreases, and the natural moisture mechanisms basically shut down.
That sounds awful.
It is. The tissue becomes incredibly fragile, which causes pain, burning, and structural laxity. And a localized volume injection, like a G-shot, does absolutely nothing to reverse that widespread tissue degradation.
So they turn to the CO2 laser, but I gotta say, when I hear the word laser, my mind immediately goes to the older, fully ablative lasers.
Oh, right, the old school one.
Yeah, the ones that would basically vaporize the entire top layer of the skin off. It seems wild to put something like that anywhere near this kind of delicate tissue.
Yeah, those traditional fully ablative lasers were incredibly aggressive. They caused massive thermal damage across the entire surface area,
Ouch.
which meant a brutal, painful recovery process and a really high risk of scarring. But the technology we are discussing today relies on a totally different approach. It's called fractional photothermolysis.
Fractional photothermolysis. Okay, let's unpack the mechanics of that. How does it differ?
So instead of hitting the tissue with a solid wall of energy, a fractional laser takes that intense light beam and breaks it up.
It fractures it.
Exactly. It fires thousands of tiny microscopic columns of intense heat deep into the tissue. We call these microthermal zones. It basically creates a grid of tiny controlled micro-injuries.
I see. It's kind of like aerating a lawn.
Yes.
Instead of taking a bulldozer and tearing up the entire yard, you punch these tiny strategic holes deep into the dirt to stimulate the roots, while leaving most of the grass untouched.
That's a great analogy. And because you are leaving 80 to 85% of the surrounding tissue completely intact and healthy, The body's response is fascinating.
What happens?
Well, it doesn't panic and form scar tissue like it would with a massive burn. Instead, the healthy surrounding tissue acts as a reservoir of healing cells.
Oh, wow.
It rushes to repair those tiny thermal columns, kicking off this massive regenerative cascade.
The body just goes into overdrive, right? It starts producing fresh structural proteins.
Yep. It forces the body to synthesize new collagen and elastin while dramatically increasing local blood flow. So in the vaginal area, this controlled thermal trauma essentially tricks the tissue into regenerating a thicker, more elastic, and well-lubricated mucosal lining.
Okay, so we have a pretty clear picture of the two procedures on their own now. We have the G-shot, which is an injected pocket of cross-linked hyaluronic acid gel acting as an internal tent.
Right.
And we have the fractional CO2 laser, which punches microscopic columns of heat deep into the tissue to trigger collagen production.
Exactly.
But knowing that lasers intentionally cause thermal damage, the patient obviously needs something to help that tissue heal afterward. And here is where the story gets really interesting, because the best healing agent turns out to be, drumroll, hyaluronic acid.
Yeah, it is the ultimate biological irony in this specific scenario.
It really is.
Because there is a massive body of clinical data looking at how to optimize healing after a fractional CO2 laser treatment. A significant portion of this research comes from facial dermatology, particularly studies treating severe post-acne scars.
Okay, and what did they find?
They compared patients who only received the laser treatment against patients who received the laser, followed immediately by the application of a topical hyaluronic acid serum.
A topical serum, so a liquid spread over the surface of the skin,
Exactly.
not a thick cross-linked gel injected underneath with a needle.
No, the formulation's entirely different.
Hmm.
Natural or topical hyaluronic acid is a glycosaminoglycan. Its primary biological job in the human body is hydration.
Right.
A single molecule of hyaluronic acid can bind and hold up to 1,000 times its own weight in water.
Which makes perfect sense for laser recovery, right?
Mm.
If you've just blasted microtopic collars of heat into your tissue, you've essentially created thousands of tiny escape routes for moisture.
Yes, exactly.
You want something to lock that hydration back in.
And the clinical term for that moisture loss is transepidermal water loss, or TEWL. The laser physically compromises the skin's barrier function.
Right.
So the studies show that applying topical HA directly after a fractional CO2 laser acts like a biological sponge and a seal at the exact same time.
Oh, that's cool.
Yeah, it dramatically reduces TEWL, keeping the tissue hydrated while it rebuilds itself.
But the sources go even deeper than just hydration, right? The topical HA actually alters the body's internal immune response at a cellular level. Like, it changes the inflammatory marker.
It does. When you cause thermal trauma to tissue, the immune system immediately releases specific cytokines to manage the damage.
Okay.
And the studies specifically track two of these: interleukin-6, or IL-6, and tumor necrosis factor alpha, TNF-alpha.
Let's actually spend a second on those, because they aren't just abstract concepts. IL-6 and TNF-alpha are the molecules that physically cause the negative side effects of healing.
Right, they make you miserable.
Yeah. They trigger the blood vessels to dilate, making the area red and hot. They make the blood vessels leaky, causing swelling.
Exactly.
They recruit white blood cells, which leads to tenderness and pain.
They are the biochemical drivers of the inflammatory phase. But the clinical data shows that when a liquid topical hyaluronic acid serum is applied to the micro-injuries created by the laser, it significantly suppresses the localized expression of both IL-6 and TNF-alpha.
Oh.
Yeah. By turning down those specific inflammatory pathways, the patient experiences a much faster rate of scab shedding, dramatically less erythema, which is severe redness, and a significant reduction in postoperative pain.
Okay, so if you're a patient or even a practitioner trying to optimize everything, you might make a very logical leap right here.
Oh, for sure.
If topical hyaluronic acid is this incredible water-binding miracle molecule that speeds up laser healing, drastically reduces inflammation, and lowers pain, then having a G-shot, which is literally made of concentrated hyaluronic acid sitting right under the surface of the tissue during a laser treatment, must be the ultimate biological advantage.
Right, sounds perfect, yeah.
You essentially have the ultimate healing agent preloaded inside the tissue you're firing the laser into. It sounds like the perfect synergistic biohack.
It is a totally rational conclusion if you're just looking at the chemical name alone.
Mm-hmm.
But physically and mechanically, it is a dangerous assumption.
Why?
What this reveals is how the physical state of a substance, whether it's a free-flowing liquid serum on the surface or a tightly cross-linked structural gel sitting deep in the dermis, completely changes how it reacts to thermal energy.
Okay, let's get into the collision then. What actually happens when you mix a targeted EAT laser with an injected filler?
So we have to look at a highly specific histopathological study titled Histologic Effects of Fractional Laser and Radiofrequency Devices on Hyaluronic Acid Filler.
Okay, quite the title.
Right. The researchers wanted to know the exact microscopic consequences of firing these energy devices at a cross-linked HA gel.
And obviously, you can't just line up human volunteers and start firing lasers at their facial fillers or G-shots to see if they melt, right?
No, definitely not ethical.
So how did they actually test this safely?
They utilized human skin samples obtained from abdominoplasty surgeries. Tummy tucks.
Oh, wow.
Yeah, they took this freshly excised living human tissue and injected hyaluronic acid filler intradermally, effectively mimicking a standard dermal filler treatment.
Okay, smart.
Then, they treated those specific marked areas with various clinical devices, focusing heavily on the 10,600 nanometer fractional CO2 laser.
So they replicate the treatment on actual human tissue, and then they biopsy it to see what happened on a cellular level.
Exactly. They took biopsies of the treated areas and used specific histochemical staining techniques. This allowed them to see the exact structure of the tissue, the depth of the laser penetration, and the physical state of the filler gel under a microscope.
And this brings up a really crucial piece of physics regarding the 10,600 nanometer laser. It is specifically designed to target and be absorbed by water.
Right, water is the chromophore.
Oh, that's how it works. It hits the water in the tissue, flash heats it, and vaporizes the cell. Now, remember what we said about hyaluronic acid? It is a molecule designed to hold 1,000 times its weight in water.
Exactly.
So when that laser fires into the tissue, it's not just going to pass gracefully through the filler, it's going to hit that highly concentrated waterlogged gel and treat it like a massive heat sink.
And the biopsies proved exactly that. The staining confirmed that the fractional CO2 laser successfully creates those microthermal zones, the tiny columns of intense heat.
Okay.
But those columns travel deep enough to physically intersect with the pocket of cross-linked hyaluronic acid filler.
Oh, no.
Yeah. The laser energy is absorbed by the water held within the gel, and the intense heat causes direct, severe thermal damage to the HA filler itself.
It just physically destroys it.
It does.
It's like taking a beautifully sculpted ice cube, dropping it in a glass, and then hitting it directly with a blowtorch. The heat completely shatters the structural integrity of the object.
That's exactly what happens. The intense heat degrades and melts those cross-linked bonds that we discussed earlier.
Right.
And remember, those chemical bonds are the only thing keeping the liquid HA acting like a firm structural gel. Once the heat compromises those bonds, the structural lattice collapses. It ceases to be a supportive implant.
Think about what this means for a patient. Imagine you've gone in, you've paid good money for a G-shot, and you now have this carefully placed volume of cross-linked HA filler sitting under the mucosa of the anterior vaginal wall, physically pushing that sensitive tissue forward.
Right.
And then later, you go back to a clinician to get a fractional CO2 laser treatment over that exact same area to treat tissue laxity or GSM.
It's a disaster.
No.
The clinician runs the 10,600 nanometer fractional CO2 laser over the active G-shot. Those microscopic thermal columns punch through the mucosa, they penetrate down into the dermal space, and they hit that pocket of hyaluronic acid.
And boom.
Yep, the cross-linked bonds are thermally destroyed.
You are accidentally vaporizing your own cosmetic investment. I mean, a G-shot only lasts 3 to 5 months naturally before the body's enzymes break it down.
Right.
By firing a laser over it, you are instantly melting away the exact volume you just paid to have put in there. Not to mention, you now have compromised, degraded filler sitting in the tissue, which might not behave predictably or offer any structural support whatsoever.
Exactly. The clinical takeaway here is absolute.
Which is?
While a liquid topical hyaluronic acid serum applied to the surface of the skin is the perfect post-laser recovery tool because, it seals in moisture, stops transepidermal water loss, and suppresses inflammatory cytokines like IL-6. You cannot mix the two internally.
Right.
You cannot safely or effectively perform fractional CO2 laser therapy directly over an active cross-linked HAG shot.
It really is a profound lesson in why the sequence of operations matters so much. If you are navigating this era of stacking aesthetic, intimate, and regenerative procedures, you have to respect the underlying physics. You can't just throw everything at the wall at the same time.
Well, no, you can't.
The physical properties of an intense thermal heat column versus a highly structured, water-dense gel mean they have to be sequenced properly.
If a patient requires both the regenerative effects of the laser and the volume of the filler, the biology dictates the timeline.
So what's the right order?
You must perform the laser therapy first.
Right.
You allow the tissue to fully heal, let the collagen regenerate, let the inflammation completely subside,
Okay.
and only then, once the thermal trauma is fully resolved, do you inject the cross-linked HA filler. You cannot put the ice cube in before you turn on the blowtorch.
Such a great rule of thumb. Which actually leaves us with a lingering, somewhat provocative thought to mull over.
Oh, let's hear it.
We know, based on those abdominoplasty biopsies, that fractional lasers cause immediate thermal damage to synthetic injected hyaluronic acid gels.
Right,
The heat destroys the cross-linked bonds.
right. That's proven.
But we also know our bodies naturally produce hyaluronic acid in our skin and mucosal tissues every single day. It's a critical part of our natural extracellular matrix that keeps our tissues hydrated and plump.
Yeah, it's what keeps healthy tissue functioning properly before any interventions are ever even introduced.
So what happens to our natural HA reserves when we undergo these extreme thermal therapies?
Mm.
If the targeted heat of a 10,600 nanometer laser melts and degrades synthetic HA, are we temporarily melting away our body's own natural hydration stores before the tissue even has a chance to rebuild the collagen?
That is a really interesting question.
Right. Like, are we taking one massive step backward in our natural moisture levels just to take 2 steps forward in tissue tightening? It really makes you rethink how we balance the pursuit of physical optimization against the incredibly delicate, naturally occurring ecosystems inside our own bodies.